Yeah, look, I know you want to have this operation. I know your surgeon wants you to have it, and I know everyone's really keen, and your insurer's happy to pay for it, but it won't help you.
Mm.
You don't have a randomized trial to show that what you're doing works. Sounds wrong, but that's the fact. If a surgeon says you need surgery, that's super powerful.
Yes.
Like, it's really hard to talk anybody out of that.
Well, all right, good day everyone. This is Jeff Walker. This morning I'm here with Professor Ian Harris. Professor Harris will be speaking at the 13th Annual Soft Tissue Therapy Conference on the 13th of October. Professor Harris is an orthopaedic surgeon who works at a variety of hospitals around Sydney, and he's on various state and federal committees, and as well he sits on the boards and committees of many professional societies. Recently, in the last couple of years, written this book, Surgery, the Ultimate Placebo, which is a real eye-opener. What Professor Ian Harris is going to be speaking to us about at the conference is perception versus reality and the effectiveness of healthcare. So the book basically details the fact that what is best for the client and the patient, and are we in healthcare providing that? And Professor Harris looks at that from a surgical perspective. So may I first ask Professor Harris, when did you realise this book needed to be written?
When I started practicing, I think. When you go through medicine and you learn from others, you see other practitioners and you do rotations and you do your internship and things like that, you kind of take everything as accepted. Mm-hmm. You think that if this doctor treats this condition this way, then that's the best way to treat it, and it must be very effective, otherwise they wouldn't do it. So there's kind of a naivety or an unquestioning nature of how people tend to go through life. Why would I suspect that it would be any different? And it's only when you start talking to other people and your eyes get open to better ways of knowing whether things work or not. So in other words, more scientific ways, less biased ways, looking at randomized control trials of some of the things we're doing, you find that a lot of the stuff we're doing in medicine, it either doesn't work or it doesn't work nearly as much as people tend to believe it does. And then you realize there's this problem. Everybody wants it to work, right? So the patients want it to work, the carers want it to work, the people providing the treatment want it to work. Everybody wants it to work. So nobody's questioning it. Nobody's going around saying, hey, what you're doing doesn't work, because that doesn't help anybody, except if the treatment really doesn't work. and then what you're doing is helping people. So I started to take a more scientific approach to medicine, and I found that the more scientific you looked at it, the less effective it got. And in my particular field of surgery, that was particularly eye-opening for people, because I think most anybody would understand the concept that some pills might not work, and that they might really just have a placebo effect, or and there's lots of debates around how effective antidepressants are, and all these other sorts of drugs that are commonly used, even opioids and things like that, are getting a beating because whether they're whether the harms outweigh the benefits. But when you talk about surgery, people don't think like that. People think surgery, there's something that works, like it's literally, cut and dried. Like it's there, you can see it. You're putting the pieces together, you're taking the tumor out. Of course it works. But when you look at it objectively, a lot of it doesn't. Sometimes taking the tumor out doesn't help the patient live. That's just sounds wrong, but that's the fact. Sometimes doing a number of operations doesn't help people. And it's only when you look at it through these objective measures that you find that out. But there's a lot of resistance to that as well. People don't want to know that.
And not just from your colleagues, but from the patients themselves, you've said in the book?
Um, yeah, I think there's just a general resistance to a party pooper, somebody who's going around saying, yeah, look, I know you want to have this operation. I know your surgeon wants you to have it. And I know everyone's really keen and your insurer's happy to pay for it, but it won't help you.
Hmm.
Um, yeah, I think there's a general resistance to that, which I can understand.
Well, you've said that in the book too, that there's people who are waiting for knee surgery on the waiting list, and by the time they get to a month or 2 months later, their knee's better, but they still want the surgery.
Yeah, that was interesting because that was referring to knee arthroscopy, which
Hmm.
has taken a lot of criticism, and rightly so. And I started to think twice about that when I used to put patients on my list for a knee arthroscopy, and it would take them often several months to get to the
Hmm.
operating room. They'd have to wait, and yeah, it was more than once that I would see patients in the anaesthetic bay ready to go into the operating room, and I'd say,
Hmm.
"How are you going? You ready for the operation? How's your knee
Hmm.
feeling?" And they go, "Oh, it's good. Yeah, yeah, no, it's fine." And I go, "Well, are you still getting the clicking? Is it hurting you?" "Oh, no, no, it's been really good." And I said, "Oh, well then, like, why are you here?" Like, why, And they go, "Well, I thought I'd better have it anyway, just in case."
Just in case. Yeah.
Yeah. So, yeah, it's a strong belief that surgery is something if a surgeon says you need surgery, that's super powerful. Like,
Yes.
it's really hard to talk anybody out of that.
Added in there, Voltaire's quote: "The art of medicine consists of amusing the patient while nature cures the disease."
Yeah.
So you seem to be a big believer in that as well. That you also talk about how incredible and how surprised you are that the body just cleans things up by itself, irrespective of the treatment that's provided.
Yeah, we tend to overestimate the role that we play
Mm,
as practitioners in getting people better. We think that if anybody gets better after we treat them, it's because we treated them,
of
not
course.
because they would have gotten better anyway.
Yes.
And I think a lot of the times people would have gotten better anyway.
Reading that book, I was just translating everything that we do in manual therapies. It's very, very similar. We think we know what we're doing and we think we're doing the right thing, and people seem to improve, but will they have improved anyway? It's the
Yeah.
perpetual question. And people generally seem to be getting better across the board. So there's,
Yeah, but I mean, historically, this has driven everything. This is every kind of healing practice,
hmm,
from faith healers and witch doctors
the
and
bloodletting.
bloodletting. This has driven everything for history.
Yes.
Is the fact that most people tend to get better.
Yes.
Uh, yeah,
Well, the other interesting thing with that too was that he had said that there's a lot of holes or there's gaps in the evidence for what you do and what your colleagues do. But then it comes down to the medical community has a double standard in terms of what sort of evidence they want from alternative therapies,
yeah,
but they don't apply the same principles to when they're looking at their own interventions.
yeah,
Hmm.
yeah. That's right. So, doctors will be the first people to criticize anything outside of mainstream medicine,
Hmm.
to say, well, you haven't done a blinded placebo-controlled trial to
Hmm.
show that that's effective.
Hmm.
Therefore, what are you touting?
Hmm.
And then I turn to them and I say, well, you don't have a randomized trial to show that what you're doing works. And they go, oh yeah, but we know this works, so there is a double standard there, I think.
There's another section in there you said that the ethics and science are distorted in order to maintain our placebos and avoid putting them to the test. So, like you said, they're doing what they were taught, what they've seen, what seems to work, and how people just seem to continue to improve in the face of what they're doing.
Yeah,
So
yeah,
they're surgeons, so they surge, as
yeah,
you put it.
that's right. I like that one.
Yeah, it's
Yeah,
good. The other incredible thing was that the chapter on the surgical scrap heap. I was quite surprised at some of the surgeries there that don't actually have any evidence to show that they're safe and effective. And there were some big heavy hitters in there, like I think every second kid that I went to school with had their appendix and tonsils out. There was always
yeah,
show and tell on Monday. They had the little jar with their
Yeah.
appendix in there. And
Yeah, that's right. You're showing your age there. Yeah.
yes. Well,
Yeah.
that doesn't seem to happen as much now.
Yeah. So, well, tonsillectomy is an interesting one because that was one of the earliest examples of where common surgical practice was questioned. And this dates back to the 1920s, I think, in the UK. And there was a particular a person who looked at this and looked at the variation in practice, how some kids had their tonsils out, other kids didn't, and tried to work out what the pattern was. And the quote from that particular person was that the best predictor of having your appendix out was to be born with a silver spoon in one's mouth. And so, in other words, it was the rich kids who could, who were getting billed to take their appendix out. Sorry, their tonsils out. Yeah.
Oh, that's right. It said that there was 1,000 kids, and
That was another study in New York, which was fascinating. They had these poor kids in New York, and they wanted to make sure that they were getting the best medical care. So they took them all to an ENT surgeon to see whether they needed their tonsils out or not. And the ENT surgeon, looked at all these kids and recommended tonsillectomy in about a third of them. And so they said, oh, great, this is really good. We're getting good care for these kids, and went off and a third of them got their tonsils out. And then they thought, we just really want to make sure that these other kids are okay. So the remaining kids, they took to another ENT surgeon. An ENT surgeon looked through the remaining kids and recommended tonsillectomy in about a third of them. And so those kids got their tonsils out. And then the remaining kids that were still left over, who hadn't had their tonsils out the other 2 goes, they sent them to a third ENT surgeon. And that ENT surgeon looked at all the kids and recommended tonsillectomy in about a third of them. And so on and so forth. And this just shows you that ENT surgeons were just recommending tonsillectomy in a third of the people they saw.
Yeah.
It didn't really matter who they were. And so you do have to question the criteria they had for recommending it.
That's for sure. I can't remember where the quote was, but there's another quote that says it's difficult to get a man to understand something when his salary depends on his not understanding it.
So yeah, that's right. That's a very common quote. It's not mine. And the other one from Carl Sagan is that it's difficult to reason a person out of something that they were never reasoned into in the first place.
Yes.
So people with unreasonable beliefs, it's difficult to reason them out of it, which is interesting.
Yes. In the book too, you kind of say that there's a confession that you do things that don't work, and that everyone does things that don't work. So do you get to a point where you say, I'm not going to do that anymore because I definitely know that doesn't work?
Yeah, so that was interesting. I kind of added that late when I was writing the book. I inserted this bit, and I thought, people might be interested to know, because I didn't want to come off as all preachy, like I'm a great doctor. Everything I do is fine, but all these other doctors are doing crazy stuff. And I thought, well, gee, I've done as much crazy stuff as anyone, and so I just put in this section saying, I used to fuse backs for back pain, do knee arthroscopies for sore knees, and all these things that we know now don't work, and I know now don't work. And I did just as many of them as anybody else. So I just put that in there, and I really, it was an afterthought to insert that into the book. But a lot of people have picked up that particular passage.
It's very powerful.
The newspapers picked it up, and they said, wow, you're actually admitting that you did things that didn't work. I'm like, yeah, like everybody does it. It wasn't big news to me, but it was a powerful message I found. So I'm glad I put that in.
Yeah, well, definitely. Well, it's you'd be familiar with Peter Gotchi, the guy from the Nordic Cochrane Centre. I mean, reading your book, I was kind of going, oh, this has got a feel about Peter Gotchi with you as well. He talks about being a hero and a whistleblower or a critic sort of thing. Would you see yourself as any one of those, or just a scientist being a scientist?
Yeah, no, I see myself.
There is a heroic aspect to what you're doing. It's
no, I don't want to be seen like that. I want to be seen as a plodding scientist who's just going through the evidence and not, because if you're trying to be a hero, then you're trying to sort of, maybe then you're going to overstate things and overreach. And as soon as you do that, as soon as you exaggerate or overreach, that is what gets picked up, and the thousand other things that are absolutely correct that you said are lost. So I am reasonably careful. In the early days, I'd just sort of say things, offhand, and people would pick it up and they go, well, that's not exactly right because what you said this, and I'm like, oh, well, sorry, and then I realized how closely people were watching what I say. So I'm a little more careful with what I say these days. And I kind of am a bit of an enemy of the hero surgeon. I don't like, this attitude of the hero surgeon that you see around the place where it's like, I'm the only one that can do this operation. I'm so glad you came to me because all these other clowns will just stuff you around, and I'm the only one that can do this operation properly, because that's a load of rubbish.
Well, the other point that you raised there too was that that when they do their surgeries, these rogues, there's very little accountability after the fact, and they don't display their results, and they don't say how well they've gone, and so you don't.
Because they don't have to.
There's no assessment.
Because everybody wants them to be a hero. Nobody wants to tear that down. And so they get off scot-free. It's a bad system, but that's what we have.
But well, it comes down to what you're saying, that we're all supposed to be practicing evidence-based medicine, but it's more consensus-based, it seems, these days, that everyone's doing, and that's in manual therapies as well.
Yeah, so this is a problem. There's a fashion, there's a trend, and it's a real social phenomenon that dictates what we do. This is a big problem, and so what we get is we get an acceptable norm. That this is the way we treat this condition, and it's lazy, it's comfortable, it's easy. And that's the way I started practicing. I said, well, when I see somebody, with a sore knee and a bit of a degenerative meniscus tear, I'm going to do an arthroscopy, because I'm never going to get into trouble doing that, because everyone else is doing it, and that's just the standard of care. So that's easy. I make money, patient's happy, they're getting something done, they'll feel better anyway. It's easy, but it's lazy. And to stand up and say, to explain to the patient, you don't need this operation, to start to try and convince your colleagues, of the same thing, it is a lot harder. But unfortunately, that's the way we need to do it. We need to have evidence for what we do. We can't just do things because everyone else is doing it.
Yeah, we had that. You would have known recently there was a public private health insurance review that was done a couple of years ago, looking into alternative therapies and whether or not they should be included as part of the private health insurance scheme in the country, because 30% is being paid by the federal government, so they want to know that they're getting value for money. And remedial massage was put on under the spotlight there as well, and that was a matter of the AMT, the Association of Massage Therapists, presenting evidence to the review committee to validate what we're doing. AMT did a great job of that, and it was, we passed with flying colours sort of thing. But some colleagues and I were discussing the fact that if a physiotherapist was going to do that, a musculoskeletal physiotherapist, what sort of evidence would they present? It would be the same stuff that we're presenting, and that there's not this magical set of studies that are flawless and randomised, double-blinded, and all that sort of stuff. So it was hard to see why we were being looked at when the same sort of evidence would be being provided by a physiotherapist if they were going to be presenting that to validate what they were doing.
I would love
So
the physiotherapists to be put under that kind
you
of
would.
spotlight. Yeah,
So validating what they do.
yeah.
So
I
yeah.
mean, there's a lot of I've got a lot of physio friends in the research world who feel the same way about physio as I do about surgery.
Mm.
There's a lot of it that's overdone, that's probably not necessary. There's some of it that's good, but it's not all rosy. Not everything we do works.
Yeah, very true. Well, it's easy when someone doesn't get better. It's easy to to see it doesn't work, but it might just be for a different reason than the technique, like you mentioned
Exactly.
in the book
Yeah.
too. Okay, well, I know that you've got another meeting coming up, so we'll perception versus reality and the effectiveness of healthcare. We're very much looking forward to hearing you speak on that. Thank you so much for your time this morning, and I'll look forward to seeing you on the 13th of October at Tradies down
Grimy
at Gymea.
tradies.
Yes, have you been there?
All right. I'll see you there.
All right. Thanks, Ian.
Thanks. Bye.
Bye bye.